Good evening, everybody. I am Francesco Sanguedolce from Fundació Puigverd in Barcelona. I'm the chair of the ESUI, the imaging section of the EAU. I'm very pleased to open this webinar today. It's a special day because it's the World Prostate Cancer Day, and dealing with this very special topic, which is incredible topic in terms of how this may have the impact in our urological activity in the next years. And I'm talking about the prostate cancer screening, the optimized prostate cancer screening, as prompted by the Policy Office of the EAU. So I'm first and foremost would like to introduce my co-moderator, Professor Albers from the University of Düsseldorf and Vice Chair of the Policy Office, Professor Albers. And obviously, as you can see from the program, there's a distinguished number of panelists that will discuss about the screening program that is going to be implemented in the European Union, dealing with the different challenges that these may involve. And so that's why we have a multidisciplinary team, talking today. And obviously, couldn't open this webinar with the main driver of the change of the EU recommendations integrating prostate cancer screening, who is Professor Van Poppel. I don't think Professor Van Poppel needs to have an introduction. He's very well known to everybody in the urology community. He's currently the EU Policy Office Chair, and he from the Leuven University, and has been, as I mentioned before, the main driver on behalf of the EU to prompting the EU Commission in integrating prostate cancer screening for the next years to go. So then we'll have the chance to introduce also the other panelists, but also they are very well known, and we will go step by step with all of them. And as a practical information, so obviously all of you will be allowed to make any question, to write them. And we have to select the main questions at the end with the question answer section. They will be in the last 15 or 20 minutes, so you will free obviously to participate. So I'm very happy to introduce the first speaker, Professor Van Poppel. Please, the chair is yours.
Good evening. Thank you, Francesco, for your wonderful introduction. I'm going to share my screen so that I'm able to tell you something about the PRAISE-U, and I will start by explaining that indeed I'm the chair of the Policy Office. I have two vice co-chairmen, Peter Albers, who co-moderates this session with you, Philip van Kerrenbroek. The manager of the office is Sarah Cullen. The manager of the PRAISE-U project is Vera Vasilieva. So she's really coordinating this project for the time being. I need to go back in history. You know that PSA has been developed in 1984. Before that time, 1 out of 2 patients diagnosed with prostate cancer died of the disease. When it was introduced, you see that immediately after that, there has been this rise in incidence noted that have been equaling later on, but this means that there has been an enormous amount of overdiagnosis. You know that in 1993 there have been the European and the US randomized clinical trials on prostate cancer specific mortality. The results, however, were controversial, were not in the same direction. The PLCO did not show any effect, but a reanalysis in 2016 showed that prostate cancer screening reduces prostate cancer mortality by 30%. But the problem was, as you can see on the right of this slide, that there was overdiagnosis in 20% in the PLCO and up to 50% in the European randomized screening trial for prostate. Remember that once PSA was used, the prostate cancer mortality decline was the most marked as compared to all other cancers. Look at bladder cancer over here. But recognizing the overdiagnosis and overtreatment which made that the United States Preventive Services Task Force in 2012 recommended against screening for all men. They already recommended against men over 75 in 2008, but now against all. The patients detected regionally with lymph nodes, with positive lymph nodes, or with bone metastasis at the time of diagnosis increased immediately. And there was, as you can see in Europe, an increase in prostate cancer mortality in 2010, 90,000 to 107,000 in 2018. What did we do? We were lucky because Ursula von der Leyen said that she would beat cancer in Europe with the Europe's Beat Cancer Plan. And she said, okay, then you have to prepare a novel way of early detection where we avoid overdiagnosis and overtreatment and where we stop opportunistic screening. And this is what we did. We made recommendations for the European Union and the European Commission with a proposal for population-based, organized, PSA-initiated, risk-stratified by invitation information letter to all healthy, unsuspicious men. And you know this algorithm, I do not go into details, but following the age group, having a PSA below 1, you come back after 5 years. Between 60 and 70, you have a PSA below 1, you never need another PSA testing. But if you're above 3, you do not get immediately a biopsy like we did in the past, but you get a risk stratification using risk calculators, volume, family history, ethnicity, etc. And after this, if you are at a high risk or intermediate risk of having significant cancer, or if you have an abnormal DRE, you get an MRI. And that's really the game changer. After the MRI, there is a new risk stratification for the PIRATES 3. If you are at intermediate or high risk, you get systematic and eventually targeted biopsies. If these demonstrate cancer, you can, if low grade, go in active surveillance or active treatment. So the game changers are the risk calculators, the MRI, and the introduction of active surveillance. So in 2018, Beat Cancer Plan, 2021, our recommendations, 2022, the Commission accepts what we propose to start screening, but it is the Council who finally said we are not going to introduce population-based screening yet. We're going to do innovative approaches investigation. And this is shortly after there was a call and the EU for Health, the EAU applied, and we got the Praise You born. What does it mean? EAU is a coordinator. We have 10 million euros for a project of 36 months, so just 3 years. We do not need to show that screening decreases prostate cancer mortality. We need to show that it is feasible, that you can start up screening programs. And we have 5 pilot studies, and we try to have data from other member states as well, and have to report back to the Commission in 26, hoping that for 27, 28, we can really start up. The Praise You consortium from 12 member states, you see them here. There's obviously the EAU, there is Movember, there's the general practitioners with Wonka, there's EUROWebinar, patient organization. You see that also the European Society of Urogenital Radiology is included in the consortium, with which we try to make a living knowledge platform on prostate cancer screening. We had a kickoff meeting in April this year, and you see that in the advisory board we have Valeria Pandebianco from the European Society of Radiologists, who is one of our advisors. And we have started up with in the first year with Work Package 2 and Work Package 3. And I will just summarize what we have done so far. Now today are starting the pilots, and so in year 3 we will have to evaluate and show sustainability. And this is one of the investigations that have been done in Work Package 2, where we have looked at the early detection policies in the different EU member states. And you see, for instance, in France and in Germany, there's a recommendation against population-wide testing. However, there is opportunistic screening in about all member states. And there is an unorganized population-wide testing today in Lithuania. That's the only country. We have made screening fact sheets for the different European Union member states so far, looking at life expectancy, looking at reimbursement strategies, etc. And you can just look on what your country is now having as recommendations. We have done a systematic review on the cost effectiveness of prostate cancer screening in Europe. We have looked at the needs assessment, looking at the current practice towards early detection, and try to identify the barriers why screening programs have not taken off, like for instance in colorectal and breast cancer, and try to find some solutions. The most critical barrier has been found to be the lack of political support, where obviously we need awareness campaigns, consensus meetings, European guidelines, together with the Joint Research Council of the European Commission. Second most critical barrier is insufficient human, physical, or financial resources, where we need to come up with compatible IT systems. And the third critical barrier is the participation, inadequate public promotion. Men do not care about their health like women do, so we need awareness campaigns, involve patient organizations, and really make easy access, for instance, by screening buses, etc. And so now we have a PraisU Knowledge Hub that is available on europe.org/PraisU, where you can look at the fact sheets for your countries. Also, we look at the data that we have obtained, for instance, on the use of PSA, that every one of you can just consult on this website. Now, the pilot sites so far are in Ireland, 2 in Spain, 1 in Poland, and 1 in Lithuania. On the other side, we will share the knowledge from what is ongoing, the organized PSA testing in Sweden, in Estonia, and also in the Czech Republic. They have been starting up a screening program. And this is the algorithm, again, that I have shown you earlier, and this is what the pilot sites more or less must implement. They can change certain things, and you will see, for instance, in Lithuania, people are invited by email and by SMS. They invite 10,000 people, of which they hope 5,000 will come for having their PSA sampled. You see in Manresa, for instance, this is a general practitioner-driven screening, which is completely different from the 4 others, where people get a physical letter. They invite 5,620, and they expect half of them of being able to get their PSA sample. In Poland, where there is a lot of PSA done already in men between 50 and 70, they expect only 1 out of 10 will come for the screening program. So this is what we need to do for the MRI, and this is interest for you. You see that the type of MRI is specified, biparametric in Poland and Manresa, for instance. Who is the reviewer? How many reviewers there are? There's 4, 2, or 1 or 2. The radiologist is always the one who reviews it, and you see that 1.5 and 3 Tesla are both used. The way biopsies are taken are also specified and different in the different pilot sites. So finally, we hope to get all these data that will be stored in the University of Luxembourg, in the PraisU registry, and in the EU Evidence Hub. And if other additional sites beside these 5 will want to share their data, they will be able to apply for collaboration. What we do for them is, so if you have a country, a member state or a non-member state, also outside the European Union, we will give you the protocol for implementation. We have a help desk. If there is any questions, we have prepared an informed consent, a patient information sheet, and a patient video, and we have obviously determined the KPIs, the key performance indicators that we want to have, and the code book where we want to show which data we want you to share with us. So as I said, we have the pilot implementation, we have the REDCap code book, and we have a video that can be shown to patients to help them decide whether they want to participate or not. So I can tell you that today we have indeed 5 EU4Health sponsored pilots. We have 2 ongoing programs in the Czech Republic and in Sweden, and we have 12 other pilots. Look, for instance, in Italy, there is 3. There is 1 in Spain, there's 1 in Austria, there's 1 in Germany, 1 in Switzerland, or 2 in Switzerland now. And after the last EAU National Societies meeting that we just had last week, we saw that also Cyprus, Portugal, the Netherlands, and other countries are willing to support us to enable a data collection from outside the PRAISE-U pilots. And this is about what I wanted to tell. We had a meeting in France, in Lyon, at IARC recently, where all this has been set up, and this is the consortium completely, and I want to leave it there. I'm gonna stop sharing my screen, and I look forward to get your questions. Thank you.
Oh, thank you. Can put my video, yes. Thank you very much, Professor Van Poppel. And as I mentioned before, if we are here around talking about this project is mostly because of your work and the one you've done in the last years, in the last decade, I would say, on behalf of the EAU. As mentioned at the beginning, so we will leave the question answer for the end. So I will then introduce the next speaker, is Professor Anwar Padani. Professor Padani is Professor of Radiology in the Institute of Cancer Research in London, member of the PIATS Committee and Radiologist at Post-Treatment Scanner Centre in Norwood, Greater London, has been also my mentor, at least from the imaging point of view. I'm very, very pleased to have him as a worldwide renowned expert on MRI in this setting as well. Thank you, Anwar, to join us, and pleased to listen to you.
Thank you, Francesco. I hope you can see the slides. So why do we think we need a reset of the current MRI pathway when we are talking about population screening? Here are my disclosures. Now, the historic pathway, as we've just discussed, results in a few men getting quite a lot of benefit, but a lot of men getting a small amount of harm. And the idea, as Heine just said, is to introduce MRI into the pathway to give us the benefit of reduction of the number of biopsies that are done. But it's possible to use MRI in a number of different ways. So if we take what is currently the modern pathway, where a patient presents with a raised PSA and then has a multiparametric MRI and a targeted biopsy, if we were to apply that scheme to a screening population,
We can listen to Anwar. Just disappear your screen.
okay, you should be able to hear it now.
Yes, we are.
I'm not sure what happened there. It wasn't me. So fewer biopsies will be done. You'll have fewer unproductive biopsies, fewer clinically insignificant cancers, and a slight improvement in the detection of clinically significant disease. So
can you share the screen? Sorry.
Right.
Sorry for that.
Okay. Okay, well, I'll carry on from where I am.
Yes.
So that's why so this is why this PRAISE-U algorithm has been introduced, as you've just heard. Now, the interesting thing about this is that if you were to look at this carefully with the eye of a radiologist, I see problems everywhere. And there are a number of problems that I see with this pathway for the MRI practitioner. But it is very clear that we need to optimize MRI and integrate it into this pathway so that we can successfully deliver the product at the end of the day. So the first thing is the protocol. what protocol should we introduce? I think most of us would agree that from a screening perspective, and this is what we're going to do in the UK, we want a fast MRI. That means a uniplanar MRI in the axial plane and diffusion weighted images, and that is it. No contrast medium. This is the advantage of the least amount of time, and of course, the least expensive. But if you look at the clinical studies that have been done following PSA screening, you'll notice it divides up roughly 50-50 with and without contrast medium. On the other hand, if you look at the pure MRI screening studies, you'll see every single study has been done with that, but it isn't me. Now, so the next thing we need to think about is what is a positive and what is a negative MRI. Now, traditionally, in higher risk populations, so early detection settings, we use 3, 4, and 5. This is clearly not applicable to the screening setting, and that is because the disease prevalence rates are lower and you want to avoid false positives. And a lot of false positives come around because of these PIRADS 3. So clearly we need to use 4 and 5 with some PSA adjustments, but this time we need to adjust not for individual risk, but for population risk. So just something else to think about when we think about MRI in this setting. Now, it's worth looking at the ReImagine study. Now, the ReImagine study was very novel in terms of the imaging protocol. In fact, all they did was they looked at T2 and a high B-value image. They did not use the ADC value at all. And in fact, they only looked at for focal lesions. They were either positive or negative. You'll see. So if your focal lesion 3, 4, and 5, that came out as positive. Everything else was a negative, or if it was non-diagnostic, the patients were recalled. So a very unique way of looking at the data. And in fact, it's very interesting when you look at this. You'll see the positive predictive value is 52%. And if you look at all the other studies, it's between 20 and 40%. So this is really quite interesting. And you'll see that there were very few men who were diagnosed with indolent disease. So this is a really interesting approach because it may make
Sorry, Anwar. Again, that doesn't matter. Yeah.
So you should be able to see that?
Yes.
Okay.
Yes.
And you should be able to hear me also. Okay. So the next thing we need to talk about. So the ReImagine study gives us some really quite unique data. The other thing we need to think about, and this has come through in 2 studies, is about the need to have dedicated readers. It looks as though if you take people who are trained in secondary care and put them into population screening, they overread these scans. And this is really important, particularly for younger men. So if you look at the PROBASE and the OPT study results, what you notice and are 3 takeaways. 1, biparametric MRI is challenging, requiring high expertise. Number 2, it is very difficult to read the prostate MRIs, particularly for younger men. And we know that younger men have lower prevalence of disease. But if you look at these studies, you'll see so many men got a biopsy. So that, to me, suggests that we need central reviews of these biparametric MRI scans using dedicated readers. So that's another reason why we may need to think about a reset. Let's take this example. So here's a young man. Okay, now you should not use AI for this, but I did. Okay, and the AI is positive, and I'm like, this is crazy. If you use the ReImagine study, you shouldn't look at the ADC either. Just look at the B2000 and the T2 weighted images and look for focality. So if you use that algorithm, this would be a negative scan. I don't know what you think, but I call this negative. But I've asked a number of very esteemed colleagues, and some of them have said that this is positive. So this is one of the issues that's going to come up, particularly in younger men. The next thing we need to think about is, how do we best evaluate? What sort of men are best evaluated? Is it all men in a particular age group? Is it pre-risk stratified? In other words, with say a PSA or some other biomarker?
Okay. It's fine, no worries. Just set the, yeah, we will share again. It is a common issue, no worries. We are enjoying anyway.
Okay, so we were talking about high-risk men. Now, clearly, we do need to screen high-risk men. So these are genetic predisposition syndromes, but we need to think about West African diaspora men. Now, clearly, these men have a very elevated risk. And if you have a large population of these types of men in your population, you should be thinking about screening them as well. And, strong family histories, for example. Now, so here is a man who is at high risk. He has a BRCA1 mutation. And here you can see a small prostate cancer, which turned out to be a 3+4 prostate cancer. You can see from a transperineal biopsy. Now, when it comes to pre-selection, and Heinz suggested we should use 3. Well, if you look at the data, you'll see it's all over the place. So, the prostagram study, and I'll show you the data, suggests 1. The Gothenburg study, 1.8. These 4 studies, you'll see 3. And then, of course, there's the age stratified approach as well. So there is variety, and radiologists need to be involved in this discussion because the glands will look different and the way we call these patients will also be different. We also have to remember that at the moment in secondary care, we are already doing too many MRI scans, okay? And if we are already doing too many men that need an MRI, and we don't really want the extra demand. So is it possible to reduce the MRI demand? Now, of course, it is possible to reduce MRI. For example, if you were to use the Stockholm 3 test, for example, that would reduce in early detection setting about 40% demand of the MRI, and 11% you would reduce the number of biopsies. And in population screening, for example, if you use a kallikrein score, you would reduce the MRI demand by 30%, and then 50% of men would avoid a biopsy. So it is possible to modulate MRI demand if we choose to do it. And that's something that needs to be thought about as well. The next thing we need to think about is what combination of MRI findings and PSA density, for example, is best, it gives you the best yield. Now, this was looked at in a simulation study. So if you were to do the old-fashioned way, a PSA density of more than 3 and a systematic biopsy, you would roughly biopsy about 10% of patients, and you would get a 1% detection of grade group 2 and above. Now, any MRI strategy will improve detection rates, but some MRI strategies are worse than other MRI strategies. So if you were to take a PSA of 1 and above and 3, 4, and 5, what you'll notice is, yes, you do improve detection rates, but the biopsy rate goes up to an unacceptable level. If you were to do the PRAISE-U algorithm, right, your biopsy rate would go down, undoubtedly, but there would only be a modest improvement in the detection of clinically significant cancers in the UK. It looks to us that this might be the best strategy, a PSA of 1 and a PIRADS of 4 and 5. So this also needs to be tested. And when it comes to the biopsy method, we also have to think about targeted biopsies alone, targeted plus systematic. I'm not sure we want to do that, or target or regional targeted biopsies, which is of course what the current EAU 2024 recommendation is. Now, if you were to test in this kind of population, what you would notice is that if you were to do MRI alone, you'll notice, as we've already said, you would have fewer men going to biopsy. This is what we've already discussed. But the interesting thing is, if you were to do a targeted biopsy alone, you'll see that's here in the orange. You'll see the number of productive biopsies would go down from here to here. The number of insignificant cancers would go down from here to here. But look, there are a few men with clinically significant cancers, grade group 2 cancers, they may not, of course, be clinically significant, who you might miss. Now, in this particular analysis, there were 10 men, and 6 of these men would have been eligible for active surveillance regardless. So it may be that the targeted biopsy approach, or the regional targeted biopsy approach, which is the new 2024 EAU recommendation, might in fact be the way to go. So what are the key insights? Everything I've shown you today is from a single time point. We do not know.
Last step. Very important conclusions. So we'll definitely wait for you to set your final slides.
Okay. You should be able to see this now.
Nearly.
Let's share. You are screen sharing, it says.
Yes. Yeah, we got it.
Okay, so what are the key conclusions from this literature review? Well, it's a single time point evidence, as we have just said. We do not know how MRI is going to behave on subsequent rounds, because we haven't even decided whether it's going to be 3 years or 5 years. Secondly, what the benefits that we've seen in early detection settings does seem to translate into the screening setting as well, which is good to see. Furthermore, we see benefits whether you pre-screen stratify or you don't pre-screen stratify. It looks as though it will work in both settings. The key limitations from what I've seen is that too many scans are being done, there are too many biopsies, and this is potentially a problem and might hurt the algorithm. There are too many unproductive biopsies, and in fact, the reader variability, especially in younger men, seems to be an issue, and we really need to take care of that. So finally, to conclude, I think it's premature to say that MRI is going to be effective in this setting. I think because we haven't shown an improvement in the detection of clinically significant disease. We've just shown non-inferiority in the majority of cases. So whether we will have a mortality impact with the use of MRI, I'm not sure is clear. It's clear, however, that we do need to optimize MRI for the screening program, technically, how we read things, but the optimal use will depend on its integration into a screening pathway, which is quality assured and cost effective. Thank you very much for listening. I'm sorry for all these glitches.
Well, obviously, I thank you on behalf of the audience, because it's very hard to restart and keep the attention, first of all, for yourself, and then to keep the people actually still engaged with your presentation. And we know how good a speaker you are. And again, so we will switch to the question answer after the Dr. Nicolaou presentation. So as you can see, we are first and foremost showed how the screening program is going to be implemented, or at least which is the project behind it, and how the MRI, which is going to be the key factor that has been introduced in the PraisU algorithm, And the next question is whether new technology, artificial intelligence, will be helpful in how maybe not now or maybe in the future, whether we are ready already now. And this is the question that we address to Dr. Papanicolaou. He's a research group leader in Champalimau Foundation in Lisbon, Portugal, and also is a machine learning imaging lead in Royal Marsden in London. And obviously, he's a very renowned researcher in the field of artificial intelligence. I'm very happy to leave to you to share. Thank you, Nikos.
Thank you so much, Francesco. Good afternoon, everyone from Lisbon. I hope I will not have technical glitches. I hope you can see my screen well and you can hear me well. So before starting, I would like to thank the organizers for inviting me to share in such an important topic my thoughts and my initial experience. So nothing to disclose related to the topic. So in the next 15 minutes, I will very briefly touch upon the background information, then present my main experiences with AI in prostate cancer, but in a diagnostic setting, and finally discuss challenges and potential solutions when it comes to screening an MRI. I think we can all agree that the PSA-only screening strategy has been challenged due to not being able to accurately identify patients that have clinically significant disease, depriving possibly them from early treatment opportunities, while in the same time resulting in too many false positives, leading to potential overdiagnosis and unnecessary invasive procedures. We also know that the diagnostic utility of multiparametric MRI is universally accepted as the modality that is very sensitive to detection of clinically significant disease due to the rich soft tissue contrast and multiple contrast mechanisms it is offering based on a combination of a high-resolution morphological imaging in the form of T2 images with physiology-based methods like diffusion and perfusion. Now, since a few years, radiologists have been developing a standardized reporting system called PIRADS that stratifies patients into 5 categories reflecting the risk of clinically significant disease. However, multiparametric MRI is not free of limitations, missing between 10 and 20% of aggressive cancers, resulting in delayed diagnosis, while the false positive findings can be as high as 50% or sometimes even higher, especially when expert radiologists are not available. Another challenge is the high inter-observer variability. Although PIRADS was designed to reduce the latter, still you may have different scores for the same patient when evaluated by different radiologists and with different expertise and experiences. In addition, the complete multiparametric MRI examination can be very long, leading to low throughput, while radiologists can only provide information related to what they visually perceive, not being able to predict future outcomes. Probably the new paradigm in population screening is making conditional use of multiparametric MRI to provide important diagnostic information in order to be considered for the decision-making, namely to proceed or not on a biopsy. Such a development has implications related to the need of producing high-quality multiparametric MRI studies that are accurately analyzed and assessed, and eventually the availability of multiparametric MRI-guided selective biopsies. In 2021, the PRAISE-U project introduced a new population screening algorithm, starting using PSA and age to select those patients that they have intermediate or high risk for an MRI evaluation, and again, depending on the MRI results, to receive a biopsy. But how AI can be involved in such a pathway? It may add value to perform more accurate risk stratification. Certainly, it may aid radiologists in detecting and characterizing prostate cancer, and ultimately recommend optimal personalized treatment options to patients. Given the limited time today, I will focus on the AI-enabled diagnosis part and try to make the case that AI-augmented diagnosis may reduce the false positive results that radiologists are subjected to today. We all know that AI is data hungry as a methodology, and to safely use this technology, someone needs to consider three factors as far as data concerns. The first is data quantity, then quality, and finally data diversity. For the latter reasons, European Commission back in 2020 funded a project called ProCancer, which main objectives were to develop and maintain a digital repository with data from patients with prostate cancer, focusing on multiparametric MRI, and then harness this data to train AI models that can respond to several unmet clinical needs in the field of prostate cancer. The consortium behind ProCancer comprises 20 partners, 13 of which are hospitals, including academic teaching centers, public anti-cancer hospitals, as well as few diagnostic centers, 5 research organizations with AI expertise, and 2 SMEs. In total, the project is focusing on 9 clinical use cases, starting from detection, characterization of disease aggressiveness, risk for metastatic disease, all the way to prediction of biochemical recurrence after radical prostatectomy or radiation therapy, assessment of quality of life, risk of withdrawal from an active surveillance program, and finally, individualized recommendations of the best treatment option. What makes this project so interesting, apart from being the largest and the most diverse data collection worldwide, is the fact that it is based on real-world data, retrospectively and prospectively acquired. The latter is very challenging given the lack of data standardization in the field of imaging and the need for high-quality data curation. In our platform, several AI tools have been developed to transform the data and move from a low-value to a high-value generation scenario for AI. Since this morning, we have collected more than 12,000 patients' multiparametric MRI together with a series of clinical data, all fully anonymized to protect patient privacy, data that has been provided to 7 AI developing teams with expertise in medical imaging AI to work on developing the corresponding AI models. I would like to showcase initial results, starting with use case 1, which is focusing on automatic detection of prostate cancer on MRI images. And here is a 76-year-old patient with a PSA of 9.6, where a deep learning-based model that my group has developed is identifying an area of increased probability for cancer with red color located in the right peripheral zone, which was confirmed through biopsy to be a 4+5 lesion. Of course, one important consideration is to discriminate Gleason group 1 from the rest in order to spare unnecessary biopsies and identify those patients that will need urgent aggressive treatment. The latter is addressed by ProCancer use case 2, where different technologies, namely deep learning and radiomics, have been developed to differentiate clinically significant from non-significant disease. Here we can see 2 radiomic signatures. On the left, extracting radiomic features only from the index lesion, and on the right, extracting features from the entire gland. We analyzed also radiologists' capability to differentiate significant from non-significant disease based on PIRAT scoring, and when keeping sensitivity to 90%, specificity was only 22%. I remind you that these are real-world data coming from many different institutions and not only centers of excellence. The radiomic signature from the index lesion and for the same level of sensitivity increased the specificity to 28%, while the one from entire gland specificity was reached 35%. These results are in more than 3,000 prospective patients from 13 clinical sites and real-world data. What is remarkable is the AI automatic segmentation models that we have developed in ProCancer. Here we see a zonal segmentation model where AI excels, removing a significant burden from the radiologist and results in more accurate quantification of prostate volume and thus PSA density, especially in cases very close to the threshold. Here is another case where a patient presented with bilateral lesions in the peripheral zone with very similar characteristics. Automatic segmentation by AI and extraction of radiomic features from the entire gland suggests that this patient has clinically significant disease However, it doesn't provide us with location information. For that reason, we have developed a novel methodology to visualize radiomic signatures by computing the probability of aggressive disease on a pixel-by-pixel basis, producing these color maps where red means high probability, yellow and green means medium, and blue means low probability for aggressive disease. In the previous example, these maps clearly shows that the lesion on the left is more aggressive than the lesion on the right, and that was confirmed by biopsy. Even when MRI quality is not superb with blurring and motion artifacts, something that leads radiologists to characterize that as PIRATS-3, radiomic signatures and maps are robust, accurately localizing clinically significant disease, as in this example. Another emerging technology, as you probably know, is based on deep learning and convolutional neural networks, like this NNU-net architecture, which is considered as the state-of-the-art for segmentation and detection of lesions. The advantage of such models is that in the presence of big data sets, they may provide high performance, like in this example, our NNU-net for a sensitivity of 86%, improved the specificity up to 54%, which is higher than the corresponding radiomics models. However, this is a small prospective data set, and we are actively testing and evaluating these models on new data. Here is the same patient, but now with a radiomic map that provides more accurate spatial extent of the lesion comparing to the deep learning-based model. Let me show you one example with non-significant disease. This is a generic AI detection model that detects both significant and non-significant disease and identifies a lesion on the left peripheral zone. And this is the same slice, but now with another model that was trained to identify only significant disease. There is no lesion since this lesion was Gleason group 1. And the radiomic map also shows medium to low probability of significant disease with yellow color instead of red. Here is another patient with a large aggressive tumor that was picked by the generic model, but was completely missed by the aggressive lesion detection model, which apparently is a false negative result. However, the radiomic map correctly identified the lesion in multiple slices. And here is the whole gland radiomic signature, also provided the corrected output, demonstrating a high probability of aggressive disease for this specific patient. In this example, both generic and aggressive disease detection models failed to identify a 3+4 lesion, while the radiomic map and the whole gland radiomic signature correctly identified the location of the lesion. Finally, a patient who was classified as PIRATS-3 correctly diagnosed with aggressive disease by both radiomics models. We also ran a what-if scenario to evaluate the effects of using AI in the decision-making process for biopsy. The results were pretty impressive, with up to 55% of patients avoiding unnecessary biopsies in the expense of only 4.6 false negatives. Okay, all these are very interesting, but can they be applicable to a general population screening scenario? And in addition, they make use of an MRI examination that is known to be lengthy in time, while we all know that radiologists are already overwhelmed and cannot manage additional diagnostic burden. So all these are challenges that we need to face with. Now, what is really important and a take-home message is that a fundamental requirement in AI and machine learning is that someone should always use a model with data that are similar to the training data set, which makes out-of-the-box use of diagnostic models to the general population simply not feasible. Not only are the imaging characteristics between the screening and the diagnostic scenario different, but most importantly, as we have seen today, the prevalence of clinically significant disease is significantly lower in the screening population as expected. A simple way to solve this problem would be to collect data from the normal population and train new models from scratch, but given the very low prevalence of significant disease, that would take a very long time. A more sophisticated approach is what is known as transfer learning, where knowledge from one domain, the diagnostic domain, is adapted and transferred to another domain, the screening domain. Someone could consider the diagnostic models as the backbone of new screening models where with fine-tuning they can adapt to screening data. The latter scenario would need only a small portion of the entire dataset to be collected, which is far more feasible than training from scratch. Another problem when introducing multiparametric MRI examinations to a screening program is the examination time, which at the moment, and depending on the scanner technology, it may go up to 30 minutes. Part of that can be related to multiple sequences needed to be acquired and provide multiparametric information, as well as the injection of the contrast agent. A potential contribution here from AI would be to acquire less and synthesize more. For example, acquire only the axial T2 and generate the coronals and sagittals, or acquire a single B-value like 0 or 50 with high SNR and synthesize the high B-value, or even skip completely contrast injection and generate synthetic DCE images. We are just scratching the surface of generative AI, and in the near future, it will be used more and more to augment and enrich datasets. Finally, the diagnostic burden can be addressed by means of sensitive AIs that can provide very high negative predicted value in the expense of few false positives. Imagine in the normal population, the vast majority of MRI exams can be handled only by AI, asking the opinion of a radiologist only in those that are flagged with increased probability of clinically significant disease. There is a bright future in front of us, and there are many opportunities to exploit AI in a manner that will help our clinicians, patients, and healthcare systems to become sustainable. And with that, I would like to thank you for your attention and happy to take your questions.
Thank you so much, Dr. Papanicolaou, for giving this very interesting talk to the future. Certainly have to face a bit of a problem in order to apply AI technology in the screening setting as compared to the elderly population, but you highlighted this very nicely. I don't see any urgent questions in the chat, but I would like to ask a little bit of a discussion in between us, perhaps, and start with a question to Professor Padani. Thank you for your really nice talk and thoughtful insights. Probably also aware of the Transform trial that is going to start hopefully soon in UK. In our Pro trial, we have seen, as you cited, a lot of difficulties in reading MRIs in the 45-year-olds, and most of the screening trials will start with the age of 50. OPT program in Sweden actually started already with 50. And I was wondering whether you would apply different MRI strategies depending on the age of the participants. So I was wondering whether the data from PRIME would really be also replicable in the 50 years old, because the youngest PRIME patient was 59. So do you see an age problem if we apply MRI in screening? And if yes, what kind of solution you may present for this?
So, yeah, so you rightly highlighted that the younger you start, the more difficult it is to read an MRI. I'm not sure there's an immediate solution to that. There's been very nice data showing that as people get older, obviously you get cystic atrophy, and then cancers become clearer as patients get older. So one solution would be to have dedicated radiologists who are not working in secondary care and get them to look at it. So, and train them to not overcall, because we know the prevalence of disease in 50-year-olds is going to be 1.2% or thereabouts. So do not overcall. And I think that was one of the big lessons that came out of the OPT as well as the German study. I don't know if radiomics would work. I think it's too early to say. Yeah, tough. Maybe use PSA density Whether that would help or not, I don't know. Or even some other kind of Kallikrein score that may help price this apart. But on MRI alone, I think it's going to be tough.
Great. I'm really valuable for your honest answers, because this is really a clinical question we have to solve before we start large population-based screening trials. And this gets me to Dr. Papanikolaou, because we in our program see nearly 50% of Pirate 3 lesions, even in reference pathology. And you pointed already out that there are no data on MRI to feed the system with these younger images, so to speak. But would you actually see a collaboration within Europe? Because as you see, the prevalence of cancers in this younger population is very low. So to feed the systems, you need at least 500 slides or something like that, or images to get it really trained. We have to do something about those guys, because otherwise we start screening with 55.
Absolutely.
Yeah.
One of the challenges that we are facing, as Anwar just mentioned, the data representations when it comes to younger ages tend to be outliers comparing to the distribution in a diagnostic patient setting. And that, in principle, is a very good reason why, for example, an AI model may drift and may produce or underperform and produce really questionable results. And that's why in the end of my talk, I made some suggestions on how practically these problems can be dealt. Of course, these are a bit technical for such an audience to explain in depth. But in principle, there are methods in computer science domain where someone can learn knowledge from one domain and then transfer it to another. So definitely we need to build these bridges between the diagnostic world and the screening world, and bringing technologies from both sides in order to produce the most accurate and relevant models for such individuals.
Yeah, thanks. I think this is a very good answer to the question, because we need a lot of research still, especially in the starting age of screening. And that leads me to my third question to Hein van Poppel. Hein, are you still there? I don't see you on the screen. If yes, I was wondering whether the classical risk calculators from ERSPC really play a role for the future, because they are still depending on DRE and volume and all this stuff. But if you start with 50-year-old in a screening, 99% of them would have a prostate size of 40 grams, so you don't need to really measure. And then I'm questioning whether the risk calculators really can help. And there were a lot of publications that were questioning the risk calculators. What do you think about this? And maybe 4K score, other additional serum biomarkers help, like Professor Padani and also Dr. Nikolaou said, to reduce the number of MRIs?
It's a very good question, Peter. You know that the importance of MRI should not be underestimated, but obviously we know that we decrease the number of MRIs needed by doing risk calculation beforehand. We can certainly eliminate 30 to 45% of MRIs by just doing this risk calculation beforehand. Obviously, look at Romania, they have only 200 MRI machines. They do not have an MRI capacity to start a screening program. You know that the most important element to avoid overdiagnosis and eventually overtreatment is the PSA density. This brings down your overdiagnosis with more than 60%. If you add any biomarker, and I've given this answer already in the chat to one of our listeners, you can add MRI, you can add 4K, you can add Stockholm 3, you can have whatever other parameter, and that they will all further decrease the number of overdiagnosis. But PSA density in the RSPC study has been the most decreasing factor of overdiagnosis. So there is certainly a place for MRI that can be afforded, certainly if we can do enough with a biparametric MRI that is less time consuming and less costly. But I believe that the risk calculation ahead of the MRI and a risk stratification, again with the Rotterdam risk calculator after MRI, will further decrease the number of biopsies and the number of diagnoses of insignificant cancers.
We don't have too much time, but there's one tough question from Dr. Fazekas, who lately wrote the review in JAMA on MRI. I think our audience is nearly more prominent than we are as a faculty. So Dr. Fazekas asked about the BRCA carriers, and I think this is a really big problem. Not only BRCA, if you take all together with family history, we're dealing with 20% of men that have somehow a family history. What's the role of MRI in such men, because they are very worried to have cancer? They go for pancreas MRI, they go for everything nearly once a year. So perhaps Dr. Padani starts, Professor Nicolaou second, and then Hein as a final and conclusion.
Yeah, there's only one study that I'm aware of, a prospective study looking at BRCA carriers, and that was from the Rabin Center in Israel. And it showed that there was a 4% single time point pickup rate. So MRI can be effective in BRCA carriers, and that's certainly something that we use. Given their higher risk, you might want to think about doing a multiparametric rather than a screening BP MRI. And the other thing we need to remember is that grade group 1 may in fact be a clinically significant lesion in somebody with a BRCA carrier, whereas maybe more indolent in somebody who's not a BRCA carrier. So these are some of the things that we need to think about. And from what I understand, was it the barcode study that has looked at these patients as well from the Royal Marsden? But I haven't seen any recent data from them.
No.
Can I address a question? Take in terms. So to the three speakers, the first is from Hein is, do you think, one of the key factors on a successful screening program is that it's easy, especially for the patient, the population, actually the men, to respond to the call. This should be easy, non invasive. But if we start including multiple layers of calls, could this affect the answer? I mean, what I'm talking about is first the PSA, then there's something that is not clear. To calculate PSA density, you may need a ultrasound scan, or to have a DRE the patient don't want to have, and then to have the MRI, and then so forth. So this might be a further barrier eventually. And the question for Anwar and Professor Padani is whether for the MRI quality tertiary center would require actually a certification of radiologist. And the last one for Nikos is whether there's a way for artificial intelligence to actually overcome the differences, the heterogeneity or the quality of the MRIs. Hein first.
You can be sure that I did not catch your question, Francesco.
Say again?
I did not understand.
Sorry. It's just
the question.
Sure. Your question is the question for you is whether to have multiple layer or test, like for example PSA first, then a reflection test to test the PSA with a DRE or transrectal ultrasound to measure the volume prostate to see whether the density is in favor or not, to have an MRI, then the MRI, and so forth. So this multiple layer may have an obstacle for the call of the population.
No, I understand. We need to make a distinction between case finding, between the clinical situation and a screening program. A population-based screening program is something where you invite someone for have a PSA sampled when this is suspicious, when it is above a certain value, that for ERSPC would be 3, then you get a risk calculation. This is completely different of a man who is prone to develop prostate cancer or is more likely. They do not belong to the screening population. I have specified the screening population that we proposed to the Commission is unsuspicious, healthy men between 50 and 70. In some countries where longevity, the life expectancy is longer, you can go up to 75. That's it. With MRI, after risk stratification, etc. If you are doing a case finding in a guy from African American origin with a BRCA2 gene mutation, he does not belong to a screening population. He is at risk and he should be starting at 45. This is not screening, population-based screening. So this is completely different from the clinical urology that we are doing, where you can apply all other biomarkers if you wish and if you can afford it.
Thank you. So the question to Anwar, we need to close in 3 minutes. So Anwar,
yes. That question again.
So yeah, the question is whether there's a need for a certification for the radiology.
Yeah, so certainly certification for early detection is coming, and accreditation of centers is already started in America, for example. I haven't seen accreditation in Europe yet, but I suspect that will come to at some stage in the future. But given the challenges of BP-MRI, especially in younger people, I can see that we will need certification for radiologists who are in the screening program.
Great, thank you. And Nikos, the artificial intelligence, yes?
Yes, certainly. The lack of standardization when it comes to data, and MRI in particular, is one main challenge, but there are two different approaches. The standardized approach brings everything to the same space, but so far it hasn't been 100% successful, I have to say. It's more like a theoretical aspect rather than a practicality. On the other hand, what we did in ProCancer was exactly the opposite. We intentionally used very heterogeneous data, exposing those data to the models with the wish that the models will pick up the more robust patterns within this heterogeneous data so they can be generalizable and reproducible. Because the problem with MRI is that it is an open-ended process, the lack of generalization, right? I mean, the standardization. New scanners are emerging, different coils, different protocols, so you can't really standardize everything. On the other hand, if you push the models to learn invariant signal within the data, since this data has to be very diverse, probably that's the way to go.
Okay.
A last burning question from my side, and apologies for that. We are talking about the screening, the need for screening general population, but we haven't touched upon how often this screening should take place.
Okay, that's also a very good point. Indeed, so there are many questions, but it's good to have questions, obviously, because it will help us, thinking about the solutions. And I'm very pleased now to, I have, a significant audience, all stuck on the screen. And then, so there are many questions also that may still answer. Obviously, I want to thank you foremost to thank again all of you as distinguished panelists who contributed to the successful webinar, and obviously the School of Urology having given the opportunity for organizing this webinar. I hope that also the people that couldn't connect to this evening could have the chance to do that in the next days. Thank you, obviously, last but not least, to the Central Office for the amazing work in supporting all these activities. Thank you, all of you, and enjoy the next one in a week. Bye-bye.
Thank you.